Another interesting study also kind of emphasized or compared the utility of physical examination, this time compared to like MRI of the brain. So basically, they're examined, the senior or the author examined 101 patient with acute vertigo. As you know, patient with acute vertigo, always in the differential diagnosis, you have to try to differentiate between the most common causes, which are usually peripheral vertigo, and the most serious causes of vertigo, which are usually central vertigo. So these patients, all of them, they have at least one atherosclerotic or stroke risk factor, and they excluded all patients with recurrent vertigo because it's most likely they have peripheral vertigo rather than central vertigo. And these patients were examined by a neuro-ophthalmologist, and all these patients had an MRI of the brain to look for stroke within 48 hours of admission. Now, this neuro-ophthalmologist did 3 physical examination maneuvers for all these 101 patients, looking for any dangerous sign that might suggest that acute presentation of the vertigo-like symptoms are not or are due to central vertigo, or basically posterior circulation stroke. So it's called the HINTS examination, and I would really encourage every one of you to kind of go and look at it and try to actually adopt and practice these physical exam findings in any patient presenting, especially if they have risk factor for stroke, who are presenting with features of dizziness or vertigo-like symptoms, especially if they're acute, and especially if this is a first or second presentation. So the first one is a normal horizontal head impulse test, and then nystagmus that changes direction on eccentric gaze, and then a test of skew or skew deviation, which is kind of a vertical ocular misalignment, which can be detected by alternate cover test. I'm not going to get into the details of all these 3 physical examination findings, but I really highly encourage you to go and take a look at them. And these are the 3 findings that might suggest infarction or posterior circulation ischemia. If the patient had impulse test being normal, if there's a fast phase alternating nystagmus, or if there is refixation on the cover test. So again, I'm not going to get into the details, but I really encourage you to go and look into how to perform this examination. Now, this examination was done by a neuro-ophthalmologist, so you can imagine they're more experienced, and their maneuvers are more sensitive than the rest of us. But still, I think with practice, you can still get better in doing them, and they're relatively not really complicated, but they just need practice. So in this patient, about 69 patient had ischemia. As you can see here, the initial MRI done within the first 24 hours will have a sensitivity of 80% and specificity 100%. But the bedside HINTS examination actually picked up all of the cases of the ischemic stroke. And of course, because it indicates there is a central lesion, it doesn't. It's not 100% specific for just ischemia, compared to the MRI, which is very specific. So the 8 cases that were missed by the initial MRI and were picked by the dangerous bedside HINTS examination maneuvers were 5 lateral medullary infarct and 1 lateral pontomedullary infarct and 3 middle cerebellar peduncular infarcts. So all like posterior circulation ischemic stroke. So this is kind of really interesting. Of course, this patient underwent a repeat MRI, and the repeat MRI after the initial 24 hours confirmed the presence of ischemia, confirming that the HINTS examination was right in picking up this diagnosis. So technically here the physical examination was actually more sensitive than the MRI. But again, these are like a small number of patients. The exam was done by a really expert in the field of ophthalmology examination, and it's a little bit hard to kind of generalize this finding to all the other patients and all the other physical examination skills done by other physicians. But still, it can tell you that there's a lot of physical exam maneuver that can be really very useful. So try to learn the HIS examination. I always try to do it in my elderly patient who are presenting with acute vertigo.